everyone. Today's session is about development of respiratory system. This is the learning outcomes. So in this session I'll be mainly focusing on the lower respiratory tract, and it also includes a part of larynx. Before I start with my session, I would like to concentrate on two cases which are related to the embryology of the respiratory system. The first case, during morning rounds, you are presented with a neonate who was born by emergency cesarean section at 32 weeks due to complications of maternal diabetes. The infant weighs 1.3 kg and on inspection, the infant had a blue tint on the skin, that is cyanosis. His nostrils flare up on inhalation and there is grunting during expiration. So that means there is respiratory distress in the neonate. So investigations were done, and this picture shows one of the X-ray of the neonate, where you can see there is on both the side the lungs. You can see the lung opacities. Okay, so after the investigation was done, the neonate was diagnosed with acute respiratory distress syndrome. So you will know about this. What is the embryological reason behind this? You will know after this session. The second case, a female neonate weighing about 2 kg was delivered after 41 weeks of gestation by cesarean section. At approximately 10 hours of life, the infant was noted to have crackles on routine auscultation. The infant's oral secretions were also increased. When intubation was done, nasogastric intubation, and chest X-ray was taken, there was nasogastric aspiration, revealed copious mucus-like white aspirate. Then the diagnosis was made. You can see in this X-ray the tube is not going beyond this level. Okay, it is going back and there was secretion. So on investigation, after the investigation, a diagnosis was done. Okay, the neonate had tracheoesophageal fistula with esophageal atresia. Okay, so again you will be knowing about this and what is the embryological reason behind this after the session or while going through the session. So the development of the respiratory system, okay, so it starts with the appearance of a diverticulum. Okay, so this is a sagittal section of the embryo. This is the head end, this is the tail end. Okay, and the red tube like structure represents the endoderm. So you know that the whole structures of our body develops from 3 germ layers: ectoderm, endoderm and mesoderm. So this red tube which I have drawn here represents the endoderm. Okay, and the endoderm are divided into 3: foregut. Okay, so this is the foregut part, then the midgut and the hindgut. Okay, till here is the foregut, this is the midgut and the hindgut. So near to the cranial end of the foregut, there will be appearance of a diverticulum. Okay, there will be outgrowth from the ventral wall of the foregut. Ventral wall is the anterior wall. Okay, from the ventral wall of the foregut, there will be a small outgrowth. Okay, which is called as the lung bud or the respiratory diverticulum. Okay, so it exactly appears in between the pharyngeal gut, which gives rise to the pharynx, and the area where the esophagus and the stomach is formed. So exactly in that between that there will be a small outgrowth approximately at 4 weeks of the embryonic development. Okay, the respiratory diverticulum appears. Later, when you see, initially this lung bud or the respiratory diverticulum have open communication. So you are seeing from the front here. Okay, so from the anterior view, if you see, this is the foregut part. Okay, and this is the diverticulum, respiratory diverticulum. Okay, so initially this diverticulum has open communication with the foregut. Okay, so this is the foregut and this is the diverticulum. So there will be a connection or a communication between those two. So later, as the diverticulum develops caudally, okay, it elongates and develops caudally, there will be formation of two ridges on either side. Okay, there will be formation of two longitudinal ridges which I have marked here. So these are the two longitudinal ridges which appears on either side, and this separates the diverticulum from the foregut. So this ridges is called as tracheo-esophageal ridges. So why it is named as tracheo-esophageal ridges? Because it separates the trachea from the esophagus. Okay, so these ridges, as the diverticulum elongates and develops caudally, okay, so these two ridges fuse, okay, they both fuse to form a septum completely separating the trachea from the esophagus. So this septum is called as tracheo-esophageal septum. So if you take a cross section here, so you can make out like this. So this is the esophagus and this is the lung bud. So initially there will be a communication with the diverticulum. Okay, the ridges are formed on either side, and as the ridges fuses, okay, so there will be separation of the two tubes, the wind tube and the food tube. Okay, so the septum is formed exactly at the center. Okay, so this is the tracheo-esophageal septum, divides the two tubes. So ventrally forms the trachea and the lung bud, and dorsally forms the esophagus. So this formation of the septum is a very important step in the development of the respiratory system. So though the diverticulum and the esophagus are separated, at the upper aspect, at the cranial aspect, the trachea is connected to the developing pharynx. So this is the pharynx. The pharynx is continuous with the esophagus. Okay. So though the diverticulum has been separated from the esophagus, so this diverticulum has the connection with the pharynx by a small orifice called as laryngeal orifice. Okay, so this is a section, coronal section taken here at the pharynx, development of the pharynx. You will be learning in the future how the pharynx are formed. On either side of the tube there will be out pouches. Okay, so this complete thing is called as pharyngeal apparatus, which has pharyngeal arches. Okay, so this gives rise to the pharynx and the neck region. Okay, so these are the arches. The mesodermal core are called as the pharyngeal arches. Outside it is lined by ectoderm, which are ectodermal lining, and they form a cleft at the externally separating each arch. So these are called as pharyngeal cleft, and internally again arches are separated by endodermal pouches, which are called as pharyngeal pouches. So I won't be going in detail about the pharyngeal apparatus. Okay, so pharyngeal apparatus, it gives rise to the structures present in the neck and also the pharynx. Okay, so the respiratory diverticulum has the connection, though it is separated from the esophagus, developing esophagus, it has connection with the developing pharyngeal apparatus, the pharynx, through a orifice called as laryngeal orifice. So you can see these are the arches. Okay, totally there will be 6 arches, formation of 6 arches. Among that 6, the 5th one appear and later it disappear, doesn't give rise to any of the structure. Okay, so the remaining is the 1st, 2nd, 3rd, 4th and 6th. So in between 4th and 6th there will be an orifice called as laryngeal orifice, which connects to the respiratory diverticulum. So appearance of respiratory diverticulum during 4th week approximately from the ventral wall of the foregut. Okay, so this appearance, the location and the appearance exactly at the 4th week depends, it completely depends upon the mesoderm. The mesoderm covering on outer covering of the endoderm. Okay, around the endoderm there will be covering of mesoderm. So the mesoderm have the influence in the appearance and the location of the lung buds. So again, this is a picture showing the complete embryo, the sagittal section. So here they have focused this part, how the pouches are formed, pharyngeal pouches, which is a part of the pharyngeal apparatus. So this is the respiratory diverticulum, which is connected to the developing pouches, the apparatus, by an orifice called as laryngeal orifice. So in general, when you see the development of the respiratory system, mainly the lower respiratory organs, which includes larynx, trachea, bronchi and lungs. So you know the histology. They have an internal lining, the epithelium, then there is connective tissue, cartilage and muscles. Okay, so mainly the epithelial lining. So the type of epithelium lining the lower respiratory tract is pseudo-stratified ciliated columnar epithelium. So they are endodermal in origin, okay, and the rest, the cartilage, muscles and the connective tissue of the trachea and the lungs, they are from the mesoderm, which are surrounding the foregut. Okay, so here I have mentioned the mesoderm is splanchnic mesoderm. So what do you mean by splanchnic? So you know in the general embryology how the three germ layers are formed. Okay, say there is outer ectoderm, inner endoderm. This is the neural tube formation exactly at the midline where the neural tube is formed, which gives rise to brain and spinal cord. Doesn't have the mesoderm in the middle. Okay, so on either side there will be layer of mesoderm. So this mesoderm is divided into three areas. One lying on either side of the neural tube is called as para-axial mesoderm. Then in the middle is called as intermediate mesoderm, and the rest, which forms the lateral most area, is called as the lateral mesoderm. So intraembryonic mesoderm is divided into three areas. Para-axial, because it is on either side. Para means on either side of the axis. So para-axial mesoderm. Then the middle one is the intermediate mesoderm, and the lateral most is the lateral mesoderm. So you all also know that the lateral mesoderm, again it is subdivided into two parts by formation of the small spaces which will join to form a coelom or a cavity called as intraembryonic cavity. So why it is named intra? Because it is within the embryo. This is happening within the embryo. So this is called as intraembryonic cavity. Okay, which divides the lateral mesoderm into two areas. The mesoderm, the layer of mesoderm adjacent to the ectoderm is called as somatic mesoderm. Okay, which is adjacent, also called as parietal. Okay, so parietal or somatic mesoderm, and the layer of mesoderm adjacent to the endoderm is called as splanchnic mesoderm, which I have mentioned in the PowerPoint. Okay, so lateral mesoderm is again subdivided by formation of intraembryonic cavity. The mesoderm adjacent to the ectoderm is called as somatic mesoderm. Okay, and the mesoderm adjacent to the endoderm is called as splanchnic mesoderm. Okay, so the endoderm part, as I told, that the epithelial lining of the endoderm gives rise to the epithelial lining takes origin from the endoderm, and the remaining cartilage, muscles and connective tissue, they arise from the splanchnic mesoderm, which is adjacent to the endoderm. Now this is the tracheoesophageal septum formation, which I have told. So this is a cross section, how the septum is formed and how it divides the two tubes. Ventrally is the trachea and dorsally will be the esophagus. But still the primordium that is the diverticulum, maintains its communication with the developing pharynx through laryngeal orifice. Now, coming to the clinical aspects, I had told at the beginning of the session, one of the case, a female neonate which had born after 41 weeks of gestation by cesarean section had problems, and when the nasogastric intubation was done, there was secretions, mucus secretions, and the investigation was done and the diagnosis was tracheoesophageal fistula with esophageal atresia. Okay, so this is due to abnormality in the formation of tracheoesophageal septum. So if this septum is not fused or incompletely formed or any abnormality in the formation of this tracheoesophageal septum, it leads to tracheoesophageal fistula with esophageal atresia, or it can be just esophageal atresia, or it can be just the fistula. So there are different types. Okay, so that female neonate had both the fistula and the esophageal atresia. So there are different types of these fistula. Okay, the most common types, this is the most common clinical case we come across, okay, during early age. So this is the most common type where you can see that the upper esophagus has a blind closure. Okay, it's blind end part, the proximal part or the upper part of the esophagus, it is closed. The end part is blind. Okay, and the lower esophagus has a connection with the trachea forming a fistula. So this is the most common type of tracheophageal fistula with esophageal atresia. Okay, so what happens whenever the neonate is, the feeding is done, it doesn't go to the stomach, it gets stuck, it will regurgitate back, there will be vomiting. Okay, and there can be, when you take an X-ray, the stomach will be filled with air, because whatever air the neonate is breathing, since there is a fistula, it can enter the lower part of the esophagus, and even the stomach can be filled with air. So these are some of the signs and symptoms. So 90% of the neonates will have this type of tracheophageal fistula with esophageal atresia. So this is the second type, B, the picture B. So there is no fistula, just the atresia at the upper part and even at the lower part. So this is called as isolated esophageal atresia. Okay, so there is complete closure. Okay, then this is the third type where there will be H type fistula. There is no atresia, okay, but there is fistula where both the ends are connected to the trachea. Okay, so whatever the food has been taken, it can enter the trachea and the neonate, the baby, can have difficulty in respiration. Okay, then this is the next, these are very less common, where upper end has a fistula and the lower end has atresia. Again, here the connections, here the connections are single, but here the connections are separate, they are separate, but here it is communicated, but here it is separate. So these two are very less common. Most common type is the first one, the A, where there is fistula at the lower end of the esophagus, distal part of the esophagus, and the proximal end is closed. Now coming to the development of larynx. Okay, so larynx, you know that it is made up of many cartilages, 9 types of cartilages, which includes cricoid, thyroid, arytenoid, cuneiform, corniculate cartilages. Along with that, it has muscles. Okay, so if you see the development of the larynx, the epithelial lining, as I told earlier, it derives from the endoderm part, but the cartilages and the muscles of the larynx, they originate from the mesenchyme of pharyngeal arches, which includes 4th and 6th pharyngeal arches. So I had told the pharyngeal arch is the lower part, 4th and 6th. There will be formation of 6 arches among that. So you can see from the front, this is the head end. Okay, this is the area where the foregut. So there will be formation of different arches on either side. So this forms the neck region and also gives rise to pharynx and larynx. Okay, so outer it is ectoderm, inner mesoderm, and internally it's endoderm. Okay, so among that, fourth and sixth arches, the mesoderm part will give rise to the cartilage and the muscles of the larynx. Okay, and also you can see initially the orifice will be very small. As the development takes place, the orifice will become bigger, it will become T-shaped, and even more bigger it becomes. Okay, and on subsequent growth of the larynx, okay, so this is the epiglottis of the larynx. Then here this mesoderm part will give rise to other cartilages of the larynx. Okay, so as the growth occurs, even the epithelial lining also grow caudally. Okay, because the larynx is growing caudally, even the epithelium lining also grows caudally, and there will be formation of two recesses. Okay, there will be formation of two recesses on either side of the larynx. Okay, recesses are the spaces. Okay, so these recesses are called as laryngeal ventricles, and the ventricles are surrounded by two main folds, which you already know, which are called as true vocal cords and the false vocal cords. Okay, the true vocal cords is the one which helps in producing the voice and also helps in respiration. Okay, so there will be formation of a space which is called as laryngeal recesses. Okay, which are called as laryngeal ventricles, and they are surrounded by two main folds called as false and the true vocal folds. So when you see the development of the muscles of the larynx, okay, the fourth arch mainly originates from the fourth arch. Here there will be development of a muscle called as cricothyroid muscle. There are many muscles in the larynx. So one of the muscles is cricothyroid. They originate from the fourth arch, and the remaining muscles from the sixth arch. So since the origin is different of the muscles, when you see cricothyroid is fourth and the remaining is sixth from the sixth arch, even the nerve supply differs. So you have learnt in the anatomy of the larynx that all the muscles of the larynx are supplied by recurrent laryngeal nerve. Okay, except cricothyroid, which is supplied by external laryngeal nerve. When you see the arches, okay, each arch has its own blood supply and also nerve supply. Okay, when you see the first, it is supplied by mandibular nerve. When you see second, by facial nerve. So the structures originating from each arch is supplied by its own nerve supply. Like the muscles which are originating from first arch are supplied by mandibular nerve. Second is by facial nerve. So like that, fourth and sixth pharyngeal arch are supplied by the 10th cranial nerve, vagus nerve. Okay, so the two branches of the vagus nerve, one is external laryngeal, that is superior laryngeal and recurrent laryngeal nerve. Okay, superior laryngeal nerve is the nerve of the fourth arch, and recurrent laryngeal nerve is the nerve of the sixth arch. Okay, so in the superior laryngeal nerve, again there are two branches, external and internal. Okay, external laryngeal nerve has motor in function, so they supply the muscles which originates from the fourth arch. The muscle is cricothyroid. Okay, and the sixth arch, the remaining muscles of the larynx, they originate from sixth arch. That's why they are supplied by recurrent laryngeal nerve. So that's why there is a difference in the nerve supply, because their origin is different. So all the muscles of the larynx, they arise from sixth arch. That's why they are supplied by recurrent laryngeal nerve, which is a branch of vagus nerve, except cricothyroid, which takes origin from the fourth pharyngeal arch. That's why it is supplied by external laryngeal nerve, which is a branch of superior laryngeal nerve. Again, it is a branch of vagus nerve. So here again it is showing different arches. As I told, this is the mesodermal core. Then it is surrounded externally by ectoderm, which forms clefts in between the core, and pouch internally by the endoderm. Okay, so each arch is supplied by its own blood supply. It has its own artery and veins, and also it has its own nerves.